Good afternoon, it's John Snyder again. Another edition of Thursday Lunch and Learn from the Newton-Wellesley Medical Group. Today we're really excited about our topic, regenerative medicine updates for sports medicine in the knee 2020. And we have Drs. Christine Eng and Dr. Joanne Borgstein here with us today. And we would just want to remind folks about CME credit. It's VURKAQ. We'll put that in the chat box. But that's the credit, and I think most people know how to get credit at this point. We also want to tease upcoming Lunch and Learns as we do. Next week, we'll hear the second part of this series, Spine Navigation Overview, from Jess Adlin and Sarah Kuntz. And then following, we wanted to highlight our Lab E-Consult program. So we're really excited about those programs. Again, a half hour of AMA credits available. We also wanted to do some cross promotion with medical grand rounds. I hope a lot of you do zoom in onto those medical grand rounds. They are 8:30 in the morning, Wednesday mornings. That comes out once a week with the link that comes in your email box. So you need to look into your email box about that. Dr. Friedman does a terrific job putting together a really relevant program Wednesday mornings at 8:30. So I would advise folks to do that. So for now, I'm going to stop talking. I'm going to give it over to our PM&R department. I'll stop sharing. Christine, you go ahead and take it. Introduce yourself.
Great. Hi, everyone. How are you? Great to have you with us. I'm just going to get some of these slides going here. Can everyone see my slides okay? Good. I'm going to assume that means yes.
Yes, we can. Yes, we can.
Great. Thank you for joining us for today's Lunch and Learn lecture. Joanne and I are part of the Newton-Wellesley and Spalding Physical Medicine Rehabilitation and Sports Medicine team. Of course, Joanne is our amazing chief fearless leader, and I likely don't have to tell any of you, but one of the best musculoskeletal diagnosticians in Boston. Back a number of years ago now, I did my fellowship with sports medicine here with Joanne and have stayed on as part of the team since at Newton-Wellesley. And we have the privilege of talking to you today about regenerative medicine updates specifically for the knee. We have no relevant disclosures. And so Joanne and I are tag teaming our objectives. I'm going to do a brief overview on the most common types of knee pathologies that may be amenable to some of these regenerative procedures. I want to familiarize you with the most common types of these regenerative medicine procedures and discuss the evidence behind these, particularly for the knee. And then Joanne is going to take over and discuss which patients may be best, our injection protocol, and help you determine when and how to refer, and also remind you of the Newton-Wellesley PM&R team. This is meant to be more of an introduction to the topic and not necessarily an exhaustive overview. But Joanne and I and the rest of the team are always available with any questions you may have. And I think that's one of the strong points of our team is how willing we are to answer any of your questions whenever you have them. I'm going to use the term regenerative orthobiologics to indicate the use of some naturally occurring or biologic substance that may stimulate the body's own innate healing mechanism and is used to treat common orthopedic conditions. Joanne and I are using some of these regenerative orthobiologics as part of one of the tools in our comprehensive treatment toolbox. Another reason we chose to discuss this today is that there's a lot of hype in the press as well as some controversy at times surrounding the use of these treatments. And I want to make sure that as primary care physicians, you will be asked about these, and hopefully this will give you a little bit of insight and some background into some of these techniques. Our goal is to familiarize you with the judicious use of these techniques and what evidence there is for them. And even Joanne has been in the paper for some of these treatments as well and gotten some athletes back onto the field. So very proud of her. We again want to emphasize this is part of a broad treatment spectrum and that the success of these orthobiologic treatments relies on optimizing a patient's general health so that they may respond to these treatments. And we also, as physiatrists, take a look at the biomechanical issues that may have led them to these pathologies in the first place. So when a patient comes to us, we're not just running at them with needles, but we're doing a large part of it. What we're doing is counseling, and we're making sure that otherwise they're optimized. So some motivation is required. I want to briefly review the most common pathologies we may use these treatments for, specifically in the knee. And here's what we see is that in particular for knee osteoarthritis or cartilage injuries, here's where the most evidence exists. There's also some good evidence for its use in patellar tendinopathy, and this is primarily what we'll be discussing today. However, we have used them clinically for the ligaments around the knee and have good outcomes, particularly for the patellofemoral ligaments, the MCL distal tears, and some of the lateral instability chronically that patients may have. You may also hear of its use, particularly with prolotherapy, which we'll go over later, for the use of nerves around the knee, and this may be helpful in specific cases. So for the purpose of this lecture, we'll mainly discuss osteoarthritis and patellar tendinopathy. In the simplest terms, osteoarthritis can be attributed to accumulated wear and tear to the joint surface or hyaline cartilage as we age. As we age, the components of the extracellular matrix also changes and becomes more susceptible to damage and less resilient over time. There are many risk factors that may increase the amount of cartilage damage that an individual may see, and some of them may be modifiable, as many of you may see in your offices as well. For tendinopathy, chronic tendon conditions we know are not generally primarily inflammatory conditions, and it's even been suggested that the word tendinitis, or the itis in general, is a naughty word. It may be misleading, and instead we use tendinopathy to denote the fact that this is a wear and tear or degenerative process of the tendon itself. It may be considered along a spectrum and with an initial inflammatory stage that often resolves spontaneously. And so over time, with accumulated wear and tear, you may get an angiofibroblastic hyperplasia, which ultimately leads to thickening and irregularity of these tendon fibers, which you can see on imaging. In the later stages, accumulated changes may result in structural failure with some partial tearing. And finally, you're left with more fibrosis or even calcifications within a less functional tendon. And this is why we think corticosteroids for tendon issues are less favorable over time, as they may disrupt the normal healing process and lead to worse outcomes in the long term. Particularly for the knee, they're not really used for the quadriceps or patellar tendon, as they may have a higher incidence of tendon rupture as well. And so our current treatment options for both osteoarthritis and tendinopathy are mostly symptomatic. We're reducing inflammation, blocking pain, which doesn't really initiate any or facilitate any healing within the damaged tissue itself. And sometimes, as we discuss with steroids, it may actually interfere with some of this process. So the steroids may interfere with proteoglycan synthesis and damaged protein within cartilage. And as you all know, it has a systemic effects if repeated injections are done. Over the years, multiple attempts have been made at trying to find disease-modifying agents for osteoarthritis, but currently there's no reliable agents on the market that may alter this disease process. Ultimately, you're left with surgical treatments. Arthroscopic debridement has really fallen out of favor over the years. Microfracture is still contentious in terms of its outcomes. And lastly, you're left with an arthroplasty, which can be quite helpful in the more severe cases. And so what do we do for our patients who are not really ready for the arthroplasty but need more than just symptomatic treatment? And this is where Joanne and I think that the orthobiologics may fill some of these treatment gaps. The most commonly used techniques are something called prolotherapy, which is dextrose and water, PRP or platelet-rich plasma, and then cellular treatments like bone marrow aspirate injection, and then microfragmented adipose transfers. And we'll discuss some of these today. So prolotherapy is generally a solution of hyperosmolar dextrose and water, or sugar water. It's not a placebo, but what it is doing is it's actually stimulating the innate healing cascade through a local inflammatory effect, natural growth factor elevation, and even some of the effect of needling itself. You often hear of prolotherapy advertised on the radio by a certain practitioner in Boston saying that it's great for a whole host of different things. I would say Joanne and I typically use prolotherapy less commonly for the intra-articular pathology within the knee, but we may use it for an in-season athlete when we want to get a player back quickly and make sure not to flare them up. Prolotherapy has the most evidence for use in small joints and sacroiliac joints, which has been fairly effective. And then we did talk about some of the neuroprolotherapy for some of the nerves around the knee, which is a little bit less commonly used. Most of the regenerative orthobiologic literature at this time exists for PRP or platelet-rich plasma, and I'm sure many of you have heard of this. Essentially, this is an injection containing autologous plasma enriched with a supraphysiologic level of platelets. Basically, we take whole blood, we're centrifuging it down to get the layer, the buffy coat, or the layer that has a higher level of platelets. And we're generally trying to exclude most of the white blood cells and nearly all of the red blood cells, which may be more inflammatory. So why platelets? Platelets are the first cells to arrive to the site of injury and initiate a healing process. They contain granules, which contain clinically relevant growth factors and may modulate inflammation. So they may regulate some of the complex processes which are involved in pain and cartilage injury in early arthritis. This is a little bit more of a busy slide, which is available for your perusal later, but it illustrates some of the current level of evidence for PRP, which is actually quite good. There's some level 1 evidence and multiple systematic reviews and meta-analyses to say that PRP is likely superior to the hyaluronic acid or your Synvisc, your Orthovisc, Euflexa injections, and corticosteroid on the order of 6 to 12 months, and they help for pain and function. Next, we're going to talk about some of the cellular techniques. And when we discuss cellular treatments, we are discussing quote unquote stem cells, but we make a distinction. These are mesenchymal cells that may be extracted from bone marrow or fat, but they're actually not functioning like stem cells. So we make this pretty clear to patients when we're referring to them. And we instead will call them signaling cells. And really these cells have more of a trophic or immunomodulatory role. And they actually serve to alter the microenvironment that they're injected into and stimulate other cells through a cell-to-cell signaling to serve in a more regulatory fashion. So we've seen changing of receptor types of T cells, changing of the macrophage function and things like that from these signaling cells, or pericytes as they're also called. And so we really try to call them signaling cells. And we discussed a little bit about where they come from, but they can be extracted from a patient's own bone marrow, adipose tissue, which is generally where we're doing it from, and there are other sources as well. You may have heard umbilical cord sources, but we generally aren't using them at this time. These treatments are often a little bit more experimental with early evidence, which is generally promising. Particularly for bone marrow, there are some larger, mostly retrospective studies. They are lower quality, but they do show some promising results. And generally, we're doing these for younger individuals who really can't consider a knee arthroplasty yet, or more mild to moderate arthritis injuries, and are not candidates for a more invasive cartilage procedure. So far, we're getting relatively good results with pain and function. And this is an in-office procedure and generally well tolerated. So the patient will come in, have their bone marrow aspirated, and then it is centrifuged down to isolate these cells and injected to the knee on the same day. And it's fairly well tolerated. The last type of regenerative procedure I will talk about for the knee is actually taking adipose tissue with these regenerative cells, or these pericytes. The adipose has a long history of use in plastic surgery, where it can act as a filler, but also stimulates some of the healing response. And there's an impressive case series regarding joint arthritis and several tendon disorders for these. This is also an office-based procedure and is tolerated fairly well. Patients always ask if I can take out a little bit more fat, or if they can donate fat to others. They get a kick out of it, and they actually really like it. But we only take a little bit, and it's really used to extract these very powerful cells that we use to inject into the knee. It undergoes a microfragmentation and a washing process, but otherwise we're not manipulating these cells in any way. And so here's actually where I pass the baton on to Joanne, and our fearless leader will take over.
Thank you, Christine. That was amazing. You covered so much. Next slide. So as Christine mentioned, we generally like to see folks ahead of time. It's almost our carrot. We try to convince folks, get them to lose some weight, get involved in their own strengthening program. We can do these when somebody is on Coumadin or on Xarelto, those medications, as long as it's just platelets and it's a small gauge needle. Otherwise, we need to talk with you and consider whether we need to hold their anticoagulation. And certainly folks who have active medical issues that are not yet optimal, we'll wait and discuss those with their primary care physician. Next slide. I'm not going to go through the details. Okay, next slide. We did this one. Next slide. Yeah, we got it. We can't do this without fantastic physical therapy. And in fact, there's a whole science now and field that's developing called regenerative rehabilitation. So it's really not just about what's injected, but how we do the appropriate rehab for the joint and for the tendon to optimize the healing response. And these are phased responses. The average return to play can be about 6 weeks, but it really depends on what you're trying to accomplish with your treatment. We've used, over years, we've learned to be more sort of aggressive in our post-procedure rehabilitation so that folks don't get stiff or reconditioned. But we have this discussion with them ahead of time, and we have them consult with our physical therapists ahead of time as well. Next slide. In terms of what to choose, I think that's, volumes have been written. I've written reviews about this as well. There are a lot of factors that go into our decision making, where someone is in the season, what their medical profile is, what the target tissue is that you're trying to address, what the literature has shown in these situations. And we've published a few different studies now looking at our own results. So we try to in the shoulder, we have something out, we have stuff out about the hip, and we're working on the foot and ankle now. So what we're trying to do is combine those and stay on top of the literature and the research and be part of that, because this is a moving target. And whatever we tell you now, I can guarantee you will be different in 5 years. The other thing in terms of which types of patients to refer, we're not here to, sell ice to the Eskimos. If somebody's got severe arthritis, they need to have that joint replaced. We're not going to be able to do much for them. But if they're on the more mild to moderate end of the spectrum, or they have a chronic tendinopathy for which there's not a good surgical treatment, these are patients we often can help. So I might see someone and say, hey, you better go and get that hip replaced. I can't help you. So we also need to be mindful of what we promise to folks and make sure we're working closely with our fantastic orthopedic surgery colleagues. And anyone we treat, we are not treating athletes or folks with acute injury. These are generally folks who have had their steroid injections, done their physical therapy, and optimized their nutrition and other aspects of their management before we treat them. Next slide, please. Okay. John asked me to also sort of bring to your attention, there are some new folks at Newton-Wellesley Hospital, Newton-Wellesley Medical Group, what the division of PM&R is about. I started here 28 years ago, and I was it. And now we've grown to 13 members of the division. On the right side of the screen, we have some very accomplished private practice colleagues. Dr. Sullivan, Finno, Elab, Gamba, all practice spine care. And Dr. Liang, also in private practice, is fantastic in terms of neuromuscular disorders. The field of physical medicine rehab actually over the past couple of decades has gotten very subspecialized, as you might imagine in many fields. I made a separate column for the academic group. We're part of the Harvard Department of Physical Medicine and Rehab, but the names of folks you see here were basically based here at Newton-Wellesley and at Spalding-Wellesley. We don't just come out like a half a day a week to see patients. This is our home. And then I included for you, what's kind of cool about our group, academic group, is that even within the sports, musculoskeletal, and spinal region, we have subspecialty interest in case it's ever useful for you. So mine is in ultrasound, interventions and orthobiologics. Alec Melliker is a superb interventional spine doc. Dr. Vora specializes in Ayurveda and alternative medicine. Christine and Steve are world-class experts in gymnastics and have written and published and educated on this, and they are gymnasts themselves. Christine and I do orthobiologics, and Steve osteopathic treatments and 10X procedures for tendinopathy. Lauren Elson also written a textbook on dance and performing arts medicine and sees patients in the cancer center. Dana Kotler has written and taught and is considered an expert in cycling medicine. And Darren Rosenberg, who's mostly at Framingham, one of our colleagues, and Rosa Cho will be joining us later this fall, also in interventional spine and pain. Next slide. I think the devil's always in the details, and EPIC is a little scary, so I wanted to show you what this looks like. So there is a button for ambulatory referral, Newton-Wellesley Hospital PM&R, and then you can get sort of anyone you want from here. The folks in the academic group at Newton-Wellesley Hospital treat folks in the spine center. The Cancer Center, Dr. El-Ab, I mentioned Orthopedics New England has Dr. Sullivan and Dr. Finno. So you can pick any group that you want, and then that referral will go through. You can specify a specific provider, or if there's something you know you want, cycling medicine or gymnastics, you can target that as well. Next slide. For logistics reasons and academic and research reasons, the actual equipment and orthobiologics procedures are done at our Spalding office in Wellesley, which is like an 8-minute walk from Newton-Wellesley Hospital. So it's actually a little bit easier. This particular Spalding place is easier to access on EPIC through the Spalding PM&R referral network through the Wellesley, and then we have a special click for regenerative medicine. If you forget this and they come to see us at the spine center, it is really not a big deal. We'll get them to the right place for the procedure at the right time. Next slide. So in summary, we're talking today mostly about the knee. There's good evidence for PRP and knee arthritis and tendinopathies. There's some promising early studies for cell-based therapies. Patient selection, education, preparation is key. All these injections are done under ultrasound guidance. We want everyone to be optimally healthy and involved in their rehabilitation. And if you, just want to reach out to us about anything, we're always available on email, EPIC, or phone. And what we really just try to do is combine sort of evidence-based treatment with our clinical experience as well. And I just have to end with, we didn't have time to present a bunch of knee cases, but I feel like timing is everything in life. Literally before this talk, I got off a virtual visit with an 85-year-old gentleman on Xarelto who has some advanced cardiac disease, has advanced shoulder and ankle arthritis, and just is not a candidate for arthroplasty for medical reasons. And he's 90% better in his shoulder pain and 70% better in his ankle pain. It's about 3 months now after PRP. So even older folks can respond to treatment as well, especially if they can't be treated with surgical interventions. So there you have it.
Joanne, we're gonna just maybe have a couple of questions, but about insurance coverage, if Medicare or any other insurance covers these procedures, and certainly you or I can take that.
The answer is no at the current time. The exception is if you're a professional athlete, you'll get it right away, that you'll be shuttled over to get it the afternoon you're injured. No, all kidding aside. So professional athletes and some self-insured groups like firefighters or police officers, we get referred. Otherwise, it's an out-of-pocket expense wherever you go.
What I will add is that the hyaluronic acid or viscosupplementation injections are generally also not as much covered by insurance. And what I tell people is that if those are not covered by your insurance, there's more evidence for PRP, and PRP ends up being a little bit less expensive than those types of treatments as well. And so in terms of options, PRP is probably better for most people than the viscosupplements when they're in this. And we're talking about around 1,000 to 2,000 for some of these viscosupplement injections as well. And those are every 6 months, where we anticipate PRP lasting a little bit longer. And then the next question is, if we refer to Spalding or regenerative, which docs are at Spalding and which ones are at Newton-Wellesley? So I'm going to go back to the few slides here. Joanne, do you want to?
Sure. Honestly, the group here, myself, Ariana, Christine, Steve, Lauren, and Dana are all doing biologic injections. And you don't even have to worry about it, because if you just call the office, they know which one of us does which type of injections, and they'll get them to the right place. So.
It's John Snyder. Thanks, you guys. That was really great. I think there was the question about insurance. I'm more interested, and I appreciate that. How do you kind of negotiate between these four little cool technologies when people come in, or do you kind of, some of them are a little more experimental and some are not as effective, or do you usually turn to the platelets as you kind of go to, unless there's a real reason not to?
I can start with that one. We are in the office not 1 minute less than an hour, going over every single, and sometimes we give them too much information, honestly. But basically, we try to be as conservative with the treatment as possible and less expensive, assuming that it has good evidence and good likelihood to work, is where we like to start for most things. And we have to have just an honest discussion with folks. In this community, you're probably well aware, we have a very educated clientele. So they often come in knowing what they know and kind of wanting a certain procedure. And then there's always the, when Harry met Sally thing, like, I want what she had,
Right.
So my golf buddy had this, or my tennis buddy had this. So there's patient preference to consider as well. Christine, do you want to?
Yeah, I would say that in particular I'm just going to go over some knee examples, but where we would use some of the cellular techniques over the PRP is maybe a younger person who has a vigorous healing response with an acute cartilage injury. And so those patients, we might say, hey, your cartilage injury, we may not see as much improvement from PRP as we may with some of these cellular techniques. I think that they can still benefit from PRP oftentimes, but some of the newer techniques like the bone marrow may be more indicated for a discrete cartilage injury. For our tendon pathologies, if they have more of a tendon tear, we think that PRP may not be enough to sort of fill these larger tears, and Joanne has a great sort of case series for larger Achilles tears, in which we use the adipose as a fat graft to act as almost like a regenerative bridge for some of these tendon cells, which may also be very helpful. We also have to take into account, like how much recovery time do they need? If they need a lot of recovery time, then if they need a little to get back very quickly, we may be less apt to do some of these larger procedures and more likely to do something like a prolotherapy or a PRP and just get them back really quickly. So there's a lot of factors that go into it. A lot of it are patient factors. And then there are some specific pathologies that we would think of some treatments over others.
Thank you so much. We're coming up on the hour. That's really helpful. One of the things, Joanne, to your point, patients come in with spools of research, but sometimes it's kind of shady where it comes from. Is there a website or a go-to place you like to send your patients to get some background information on this?
That is an outstanding question. I cannot underscore that point enough. There is terrible misadvertising out there. People are using the term stem cells and regeneration and promising things that are absolutely not true and probably illegal to be advertising. Some of the more reputable groups, I'm working on a position paper now with the American Medical Society of Sports Medicine, and I think they're quite reputable. There's a new organization called the Biologics Association, which is cross-disciplinary and includes orthopedic surgery, arthroscopists, non-surgical sports medicine, and we're developing not only information for practitioners, but for patients as well. So Biologics Association, especially if you're a physician, has some great data and great information embedded in it. American Medical Society, and our own society, the American Academy of Physical Medicine and Rehab. And if there's any interest beyond that, I'm happy to share some of the reviews we've written. We have one on spine, one on hip, one on shoulder that's coming out, and there's up to date is probably within the last year. So.
That's terrific. Thanks again. We're coming up on 1 o'clock. I don't see any other questions in the chat box. I did put the code in there. Dr. Panisian reminded me to put it in there, and I did. I appreciate, thanks you guys, Christine and Joanne. Great to see you, and thanks for taking the time. I can tell you personally, they've taken care of my patients over the years, and it's been great. So please continue to reach out to the group. And we hope to see everyone next week for next Thursday. Everyone have a nice weekend. Enjoy the NFL while it's still occurring. And we'll see you all next week. Bye.
Thank you.
Thank you.